Good afternoon, everyone, and welcome to this edition of Jaipur Surgical School, which is an extension of the Jaipur Surgical Tutorial, which we have been running for last more than 3 years. And the topic today is gallbladder cancer, which for Indian surgical students and surgeons is very, very important, especially those working in North India. But I think even in areas where gallbladder cancer is not common, more and more cases are being seen as incidental gallbladder cancer after the histopathology of the gallbladder removed for gallstone disease. So the speaker today is Dr. H.H. Nag, who's the chief of GI surgery at GB Pant Hospital in New Delhi, which is one of the leading tertiary care hospitals in North India, where gallbladder cancer is very common. And he is with gallbladder cancer. And to moderate the session, I have Dr. Anu Bihari, who's now the Chief of Surgical Gastroenterology at the prestigious Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow, where I also worked for more than 30 years. And she has been one of the leading contributors to the science of gallbladder cancer, not only in India, but all over the world, and has deep insight into this disease. So that I hand over to Dr. Anu to start moderating the session, and then hand it over to Dr. Nag.
Thank you very much, sir, for inviting me to be a part of this. And it's my pleasure to welcome Dr. Nag and for him to talk to everyone about management of gallbladder cancer. And we can have questions at the end of the session, once end of his talk.
Which enable my sharing of screen is disabled. Good afternoon, Kapoor sir and madam. Good afternoon, everybody. I'll be presenting surgical management of gallbladder cancer in brief. Patient with gallbladder cancer usually account for 2/3 cases of all biliary tract cancer, and most of the patient with gallbladder cancer usually present late to us because early symptoms and signs mimic benign biliary diseases, and most patient when present to us usually has either hepatic invasion, lymph nodal metastasis, and distant metastasis. That is the most common reason for poor prognosis in these patients. These patients may present as an incidental finding at the time of cholecystectomy or incidental finding at the time of histopathological examination, or they may be detected for as a mass on imaging, usually on ultrasound. Some patients may present with the jaundice also. Workup of these patients, once they are detected by ultrasound examination, usually all the patients should undergo contrast enhanced CT that should include chest, abdomen, and pelvis, and MRI should be done in all cases with suspected involvement of a bile duct and patient presenting with jaundice. PET CT should be used selectively, usually in patients with advanced gallbladder cancer, T3, T4 disease, and patients who are being planned for the neoadjuvant or adjuvant chemotherapy. Tumor markers should be done as they are useful for the follow-up. Once patient of incidental gallbladder cancer referred to us, we should examine all the reports of the patient, and all the specimen and slides should be requested for review at our center. We should confirm what is the T stage of the disease. Cystic lymph node, if present in the specimen, should be examined for presence of metastasis. Cystic margin, if reported by the pathologist, should be checked. Any history of bile spill, gallbladder perforation, stone spill in the operative records should be checked, and we can also talk to the surgeon who did cholecystectomy. Any presence of residual tumor should be assessed. Any signs of inoperability should be assessed. Now we have assessed everything. A patient who has got carcinoma in situ or T1A disease without cystic margin positivity, cystic lymph node if present, it was negative, there was no history suggestive of bile spill or stone spill. We should just observe, nothing more should be done in these patients. Patient T1B disease and T2 without cystic duct margin involvement. There is no cystic lymph node positivity. There is no history of bile or stone spill, no scar nodule, no jaundice, no evidence of any metastasis or dissemination or any signs of inoperability. Patient is fit for surgery, should be taken for the re-resection. Patient with T3 disease, T4 disease, lymph node positive, cystic margin positive, history of bile or stone spill, and jaundice or presence of bile duct, involvement of bile duct on imaging should be considered for neoadjuvant treatment, followed by reassessment for the re-resection. Patient with supraclavicle lymph node positivity, malignant ascites, involvement of non-regional lymph node, middle main hepatic artery or left hepatic artery involvement, main portal vein involvement or left portal vein involvement, secondary biliary ductal involvement, IVC involvement, or patient who are unfit or refuses surgery should be considered for primary chemotherapy and palliation. This is one patient who presented IGVC, presented with multiple hepatic metastasis that was referred for the primary chemotherapy. This is the NCCN guidelines for incidental gallbladder cancer. Once they present with T1A, nothing should be done. Cystic duct node positive should be given neoadjuvant therapy, then reassessed for surgery. T1B disease or beyond should be assessed. Resectable should be go for the resection, otherwise referred for the chemotherapy. Same is the protocol for the patient presenting detected at the time of surgery. If surgeon is expertise is available, other resources available, patient is resectable on thorough examination on table should be considered for the resection. Otherwise, patient should be referred for chemotherapy after confirmation of diagnosis. Patient who are detected on table at the center where expertise is not available, nothing should be done, should be referred to a center, hepatology center as early as possible with all the records. Patient with the jaundice, gallbladder cancer with jaundice, usually jaundice occurs due to direct infiltration of bile duct or compression of bile duct due to bulky lymph node. Some cases, intraluminal tumor extension may also lead to the jaundice. Coexisting disease like CBD stone and biliary stricture may also cause of jaundice in few patients. Sometimes extensive bilobar hepatic metastasis may also lead to jaundice. Patient with jaundice has got very poor resectability rate. A series from our hospital shown only 1 of 7 patients were resectable. And NCCN also considered is relative contraindication for the surgery. This is the NCCN protocol. Jaundice patient thoroughly assessed. If resectable, considered for neoadjuvant treatment, then reassessment and surgery. Unresectable should be referred for the systemic therapy. Patient with metastatic disease should be directly referred for the systemic therapy and palliation. This is a recent meta-analysis regarding patient presenting with jaundice. Resectability rate was 26% in patient with jaundice in comparison to 60% in patient without jaundice. R0 resection rate was 53% in patient with jaundice in comparison to 92% in patient with no jaundice. Major hepatectomy rate, bile duct resection rate, vascular resection and reconstruction rate was significantly higher in patient with jaundice in comparison to patient without jaundice. Patient with jaundice had significantly higher morbidity and mortality. Overall prognosis was worse in patient with the jaundice. Gallbladder cancer patient with jaundice. Authors concluded preoperative jaundice in gallbladder cancer patients seems to be contraindicated to curative resection, and optimal therapeutic strategies should be identified via multidisciplinary team rather than surgery alone. Candidates for curative surgery should be highly selected and experienced centers are preferred. Therefore, Gallbladder cancer patient with jaundice needs multidisciplinary team at a high volume center to reach the optimum outcome. Some of the patients with gallbladder may be detected on the ultrasound. T1A usually not detectable on ultrasound, which is usually first imaging. T2 and beyond patient are usually detectable on ultrasound that may be diagnosed. Once patient detected on imaging, they should be thoroughly examined, and if resectable, we should proceed with the resection. If unresectable, we should refer for chemotherapy. This is a case 68-year-old lady presented with pain abdomen, no positive finding on clinical examination. Ultrasound examinations on 15 calculus with 4 into 2 centimeter mass in gallbladder fundus. PET CT was done outside, 4 into 2 centimeter mass involving gallbladder fundus with high SUV max. FNAC confirmed adenocarcinoma. Patient referred to us for opinion. This was PET CT was done there. We repeated CT that shown 4.4 centimeter mass involving gallbladder and infiltrating segment 5 of the liver. Periportal lymphadenopathy was present, and largest lymph node was 2 centimeter. In view of advanced disease, we refer for neoadjuvant treatment. This is the post NACT PET CT that shown partial response, no significant lymphadenopathy. Blood investigations were normal except raised tumor markers. Preoperative CT shown 5.4 into 2.8 into 4 centimeter lesion involving fundus and body of gallbladder. There was no other infiltration, but there was a lymph node, 11 lymph node was present. We considered patient for laparoscopic extended cholecystectomy, segment 4B5 resection. Intraoperative, there was patient was intraoperative and postoperative course was smooth. I will present a video recording extended cholecystectomy. Patient for laparoscopic extended cholecystectomy should be selected properly. Usually early disease T1B, T2, or some selected cases with minimal liver infiltration can be selected. Patient with extrahepatic involvement should be avoided. Patient position is supine. Central venous pressure usually kept 5 millimeter mercury or less. Adequate exposure is must, and meticulous dissection is necessary. Judicious Springle maneuver may be used, and bowel and gallbladder handling should be kept to minimum. Cystic duct margin should always be centrofrozen. This is the mass involving fundus and body region. All patients should undergo staging laparoscopy. Staging laparoscopy in this patient didn't show any metastatic deposits. You can see there is mass. Then we proceeded with the 4-access port. We reassess the patient for any signs of inoperability. Then once it is okay, then we proceeded with the taking down of SDL first and dissecting SDL lymph nodes around all lymph nodes around hepatic artery, portal vein, and CBD should be excised. This is the you can see one hepatic artery lymph node is visible here. Lymph nodes may be removed separately or in bulk also. Only positive thing, removing in separate groups, we can label them and examine them separately. Now we move to the calyx section. This is the cystic artery clipped and divided. Cystic duct should be clipped as close as possible to the CBD, but should be careful to avoid any bile duct obstruction. This cystic margin was negative for malignancy in this patient, so we proceeded with the lymphadenectomy, and these are the lymph node around hepatic artery. While walking with the harmonic scalpel, we should be careful to avoid injury. Safe distance should be maintained from the portal vein and CBD to avoid thermal injury to these structure. You can see hepatic artery. This is the gastroduodenal artery. This is the hepatic artery course, and this is the gastroduodenal. Lymph node along gastroduodenal are being removed. Almost most of the lymph nodes from this area has been removed. This is the portal vein which is seen. These are the lymph node chain along the portal vein. We should be careful while working along the portal. Sometimes portal vein may be missed for the lymph nodes. as it is also in bluish in color. Once we have completed completed lymphadenectomy, then we prepare for the Pingel's maneuver and proceeded with the segment 4B5 resection. We access pedicle and the umbilical fissure and divide them, isolate them and divide and clip. This is the one pedicle of segment 4B, clipped and divided. After that, we'll get this is the demarcation line we have obtained. Then this is the second. You can see this area is still colored, not discolored. Now it has been discolored once you clip. So segment 4B demarcated, and now parenchymal transection should be done bit by bit, and all the hepatic venous branches, pedicles should be clipped and divided. So the middle hepatic. Sometimes it is necessary to keep single maneuver while dissecting towards this thing hilum to reduce oozing from the raw surface and visualize the vessels properly. You can see vision has improved. This is also a middle hepatic vein branch is clipped and being divided. This is another. This is segment 5 pedicle clipped and divided. Now we will release finger to see the demarcation line. Or you can see demarcation line, and along that demarcation line we will complete segment 5 transection, parenchymal transection to complete segment 5 dissection. Specimen should be kept in endo bag, and better to keep on other side to complete the procedure. Some lymphadenectomy is still remaining, so we'll complete the lymphadenectomy part, especially around the CBD. You can see portal vein and all are bare. Posterior to CBD, there are some lymph node which needs to be removed. This is a hepatic artery, portal vein, and this is CBD. Usually there is at the lower end of CBD, there will be a lymph node, and it usually accompanied by a portal pedicle, so it is better to clip it and remove. This is the specimen, and this is the scar. Now a small video about wedge resection. Parenchymal transection can be done as a wedge also, just 2 to 3 centimeter of parenchyma mark around the gallbladder to ensure R0 section, and easily parenchymal transection is completed. This is the Thank you. Thank you all.
Thank you very much, Dr. Nag. Now, if there are any questions from the house, maybe till the audience is warming up to ask any question. There was a comment because in the presentation when you were presenting a patient with CAGB, there was mention of an FNAC. So just for the listening, that if on preoperative imaging, gallbladder cancer is resectable, usually we wouldn't do an FNAC. And
Host can unmute
may I please ask everyone to mute their mic? Sir, may I ask everyone to please mute their mic?
This thesis has been submitted to thesis study.
Hello. Is there, I mean, how do you choose between segment 4B and 5 and a wedge? Or because oncologically, I think both of them are equal in terms of survival or recurrence. So is there any patient in whom you would go specifically for segment 4B5 and in some others for a wedge?
For the sake of patient, usually I do, mostly I do segment 4B5 nowadays. And because I feel more comfortable, and pedicle ligation makes in laparoscopic it makes more easy to operate on. Second, in patient, especially for patient where I think we should prefer segment 4B5 with patient with hepatic infiltration. If patient has got T3 disease as a hepatic infiltration, this patient needs obvious hepatic infiltration on imaging. We should prefer for segment 4B5 to ensure the better margin or zero resection. I think these are the patients we should do. Otherwise, there is no, you are right, there is no evidence to support this, there is any benefit, survival benefit as of now.
And I think, like us, you also do a staging laparoscopy in all the patients.
Yes, sir.
Yeah, because I think again for these students in gallbladder cancer, at least even after all investigations, laparoscopy may pick up
Yes,
such
ma'am.
small
We should
surface liver and peritoneal.
actually we should place extra port also before we proceed, and we should before resecting we should reassess the patient for the undersurface of liver and some areas which are not just by camera port who are not accessible. Then we should, and especially when we take down the SDL hepatoduodenal ligament, we should assess the lymph nodal disease, especially in celiac area. If there is involved, then we should take for frozen. If it is positive, we should abandon, I think.
I was just going to ask you that, so I'm glad that you mentioned this. Like, what about the interaortocaval nodes or the celiac nodes? Also, we also consider that once celiac nodes are
Celiac, ma'am, usually what we do earlier, we used to do aortocaval and lymph nodal, all other lymph node sampling on staging laparoscopy, but now we prefer to evaluate patient by endo ultrasound.
Okay.
So any patient with where it is enlarged and sampling was negative, then we will go ahead and do the aortocaval sampling and frozen section. Otherwise, they are not enlarged, then we don't do the aortocaval in these patients if we have evaluated them by endo ultrasound. If it is not possible, then we will go and evaluate them for that area first. We should do that first.
Correct. So, I mean, that way, I think both of the centers are quite similar about the approach, because interaortocaval lymph nodes in gallbladder cancer is akin to a metastatic disease. I agree. So, anybody from the audience would like to ask a question? Otherwise, it will become a talk between me and Dr. Nag. We just feel like talking to our own selves because we are very similar in our
nice talking.
Yeah.
Sir, this is Dr. Desai from Hyderabad. Do you routinely use PET-CT as a part of your investigation protocol, both for re-resection and as the primary investigation modality?
I think for re-resection we use, because most of the patients are referred from outside, and if patients are being referred for chemotherapy, then we use. If patient were operated, our patient turn out to be incidental gallbladder cancer, we don't do. But if a patient has got T3 disease, residual disease on CCT, and any where we are not sure about beyond, even if it is T2, we are not sure about the bile spin and all, then we should we usually evaluate for neoadjuvant this thing PET-CT evaluate with for our record, then refer patient for this thing neoadjuvant therapy.
What are your endpoints in neoadjuvant therapy where you say I'll go for resection, or you will say that nothing further can be done for this patient? What is your percentage like?
Percentage, it is difficult because with that point we have not assessed, but basically neoadjuvant is with the intention to check the tumor biology. If patient is showing response and it is then we will happy to resect that thing. If patient is not responding, then we usually ask for the change of regime, and if they further respond, we can consider for. Otherwise, we don't consider for resection. It is mainly for to assess tumor biology. If patient is responding, then if it is resectable on usually 3-4 cycle they give, and we reassess after that. If it is resectable, then we'll resect. Otherwise, we refer patient for chemotherapy. Usually they go for chemotherapy if they are not responding.
And I think even in the neoadjuvant group, the patients with jaundice, after biliary drainage, you send them for neoadjuvant. These are the ones who are highly unlikely to come to resection even after preoperative chemotherapy, at least in our experience?
Yes, ma'am. In usual setting, actually, I stopped doing direct upfront surgery in patient presenting with jaundice because there are two problems. If you resect, they usually require extended right hepatectomy and portal vein embolization, all which is not available. And most of the patient, 50%, 60% patient will have post-hepatectomy liver failure and die. And some patient who survive, they after 3-4 months recur and comes back to us. So it is better to do PTBD or endostenting and then refer patient for the neoadjuvant treatment to assess tumor biology. If they are responding, then we will be happy to resect.
Yeah, because in our experience also, what we have seen is that in patients with jaundice, one thing is that they require more interventions than those with non-jaundice patients. So they require biliary drainage, and as you said, most of them require an extended right hepatectomy. So many of them end up with a portal vein embolization. So all the time that is required in between, at some point, the patient metastasizes. I mean, we have not been able to resect even one patient after our portal vein embolization. Patient has metastasized.
I think initially when I joined GV Pant, I did around 10-15 cases, and then my experience was bad and changed my distinct practice and start sending them neoadjuvant. And after that, I hardly resected any patient because most of them turn out to metastatic in few months.
I mean, at least now I feel that most patients with gallbladder cancer, even though we manage so many of them, we still do not have clear answers for a lot of things. And probably we should start collaborating so that we have enough numbers and treat patients as part of prospective studies or trials to have
yes, we should do, I think. We should do multi-center trial, I think.
Like even for incidental gallbladder cancer, though we do say that, like, above T1B and T2, we should re-resect. And I always used to tell Dr. Kapoor that if we see the results, then the best results are in those in whom there is no residual disease at surgery.
Yes,
so basically, we have removed normal tissue. And because we have no way of finding that out preoperatively with 100% specificity, we subject all of them to surgery. And so they're also like, there are no trials to say, okay, these patients we probably should randomize to pre-op chemo therapy, upfront surgery.
Yes, ma'am.
Surgery and adjuvant.
I think that will give an answer, because this discussion also came while recently at JSF meeting past.
Yeah.
that discussion we had.
Correct.
We should do, I think, we should randomize these patients and then check.
Yeah. Are you giving neoadjuvant therapy after, adjuvant therapy after resection, or you choose patients and are selective about it?
In non-incidental cases, usually we were coming to us directly if this is T3 disease, a patient with minimal hepatic infiltration and without pancreatic infiltration. We take up upfront surgery. T1, T2, of course, we take, but in T3, we select out any patient with CVD involvement. We don't take polyvisceral dissection. If polyvisceral dissection is required, we usually refer for neoadjuvant. But any patient we can achieve R0 section with just extended right hepatectomy. Segment 4B5 dissection we do upfront, and duodenal dissection or segmental colonic dissection we do upfront. Because neoadjuvant also we have not feedback is not very good. These patients, most of the patients don't turn out to be resectable after neoadjuvant. Like colonic and esophagus, response is not as profound as in colonic malignancy and other malignancies. That is still to be achieved in gallbladder cancer, I think.
So still a lot of work needs to be done in gallbladder cancer, which is. There are no questions from the audience.
Actually, Anu, in these sessions, the online live participation of audience is indirect through the YouTube. So there will be no questions there, questions, and generate a discussion.
So if it's like that, then for the students, Dr. Nag, what is your take on port site metastasis?
Port site is isolated excision is not recommended, ma'am. This is usually enough data to say that this is the part of metastatic disseminated disease. These patients usually have disseminated disease, may manifest later, sometimes later, if it is not, even if it is not visible in PET scan. So we usually refer these patients for chemotherapy and reassess the patient after completion of chemotherapy. If we feel that this is the on PET scan, this is the only area which is showing up, then we can consider resection. But mostly it is a disseminated disease.
And when a patient is referred from outside with a diagnosis of incidental gallbladder cancer, are you doing routine port site excisions or no?
We usually don't do port site excision.
And in incidental gallbladder cancer, right in the beginning, you had said incidentally detected at surgery and incidentally detected after histopathology. And you had made a difference between a surgeon capable of doing the radical surgery required. And I think that's important. But also, I think one reason would be that if you are working in a center where your suspicion for gallbladder cancer is very high, it would
Yes,
be
sir.
highly unlikely that a CAGB escapes the
Yes, ma'am.
preoperative investigation. So we would never have this scenario where a patient is
That's
coming.
what we usually have T1B, T1 lesion. Beyond T1, we don't have at our center. Some cases maybe acute cholestatic. Some cases it is missed on the frozen also, and they re-examine and frozen this thing paraffin section comes out. Then it turn out to be there are very few, 1 or 2 cases per year we have initially reported as xantho and then turn out to be malignancy. In such cases may have beyond T1 T1 also.
So apart from the surgical expertise, I think another thing would be that these patients would not have been properly staged. So
Yes.
like if you have not picked them up on preoperative investigation, it's highly unlikely that you have staged them properly, and therefore the
Yes, sir.
choice of therapy would be different. So if a surgeon has discovered that is dealing with a gallbladder cancer incidentally at the time of surgery, the best course probably would be to come out and refer the patient to a center where the patient can be properly staged and then offered proper
sir.
treatment.
I think we should know about ultrasound. Who is doing ultrasound? If we are comfortable, who is doing ultrasound, we don't know how is he on that doing ultrasound, then we should repeat it ours. And as a policy, we repeat any patient with cholecystectomy we don't take without repeating ultrasound at our center. It is mandatory to have ultrasound at our center.
Yeah, that's true. We also do that. And because many a times, actually, when patients are referred to us as incidental gallbladder cancer, when we go in the history, when we go in the preoperative workup, we find that there were subtle clues which the operating team had
Yes, ma'am.
missed. And so they are not truly incidental.
Actually, they are missed gallbladder cancer. Missed by ultrasoundologist, then missed by the surgeon also.
Yes. Anything else you would like to add, Dr. Kapoor?
Anu, I'm sorry today. Actually, I was in between doing some administrative things, so I was not able to listen to the entire discussion. But whatever little I could hear, the jaundice part, I think most large series have shown that jaundice is definitely a poor prognostic factor. What I tell students and practicing surgeons is that you need to use the CT and MRI imaging to delineate as to what is the pathophysiology or the mechanism of causation of jaundice in a particular case. The commonest cause, of course, is a GBC neck tumor, which is involving the CBD by direct infiltration. And at the same time, it has infiltrated the gallbladder bed, the liver. And at that point in the liver, the right portal pedicle, especially the right anterior sectoral portal pedicle, is lying only at a distance of 2 to 5 or maximum 9 millimeter. So if it is a GBC neck with CBD infiltration causing jaundice and there is liver infiltration also, you will have to sacrifice the right pedicle, which means the right hepatectomy and then some part of segment 4 and CBD excision. But there could be few favorable situations. So one favorable situation is when it is a GBC neck tumor or a cystic duct tumor, which is involving the CBD, but fortunately, the liver is not involved. So it's a T2 lesion, T1 or T2 lesion, which is causing jaundice. In that case, an extended coli with CBD excision may be appropriate. So it depends on how you find the Calot's triangle. If the Calot's triangle is virgin and there is no infiltration by the tumor of the liver, so that is one favorable situation. The other favorable situation is when the tumor is in the fundus and body. It is not direct infiltration of CBD, but these are nodes in the hepatoduodenal ligament or at the porta hepatis or in the retropancreatic area, which are causing extrinsic compression of the CBD, and that is the cause of jaundice. In that case, again, an extended cholecystectomy or a radical cholecystectomy with good nodal dissection would be good enough. And last, of course, is a kind of coincidental finding that you have gallbladder cancer, but there is no CBD infiltration. There are associated gallstones, and one of the stones has come down in the CBD and is causing jaundice. So very favorable, very fortunate situation. So you should do a good evaluation of the CT images and the MRCP images and look for one of these favorable situations. Because if it is GBC neck tumor, which is infiltrating the liver and causing jaundice by direct infiltration of CBD, then of course the process starts. First, you have to consider and evaluate whether the patient is fit for a future major surgery. Then you have to bring the bilirubin down to an acceptable limit. Then you have to assess the volume. If the volume is less, you may have to do a portal vein embolization. So all this process takes at least 6 to 12 weeks time. And during this time, what we observed at SCPGI, although we could not publish this observation, is that for various reasons, whether it is disease progression, whether it is social reasons, whether it is cost, whether it is complications of these interventions, or any other reason, out of 10 such cases where you start preparing them for a possible major liver resection, less than one would reach up to the final stage. And then also, as the GB Pant experience has shown, even if you are able to achieve a resection, an R0 resection, somehow the outcome of these patients is not as good as those without jaundice. So patients with GBC and jaundice need to be evaluated very carefully. Second important point, especially for practicing surgeons, is that good ultrasound evaluation of a patient thought to have gallstone disease. The ultrasound should be done by an experienced sonologist, and all of us should impress upon our radiology colleagues that when they are doing an ultrasound for a patient with gallstones, they must look at the gallbladder wall and report how thick the gallbladder wall is. And if it is thick, that is more than 3 millimeter, they should carefully see and report whether it is uniform, diffuse, regular thickness of the entire GB wall, which is likely to be benign, versus whether it is non-uniform, focal, irregular thickening, which is more likely to be malignant. But we have been saying, and now more and more people agree, that any thick-walled gallbladder should be further evaluated for better delineation of the gallbladder wall by either CT or MRI. And all thick-walled gallbladders should be considered as suspected cancers. And it goes without saying that all gallbladders, even if they are looking grossly normal, should be subjected to histopathology, because that's the only way you will detect an incidental gallbladder cancer. Incidental means, by definition, that gallbladder is grossly normal. It is only the histopathology which detects the cancer. And these are early, these are resectable, these are eminently curable gallbladder cancers. So that is why we say that all gallbladders must be subjected to histology, and we should be careful that somebody looks at the histology. There have been cases where biopsy was done, it reported malignancy, but nobody bothered to look at the report and the patient was neglected. So that should not happen. And unless it is a T1A cystic node negative, no bile spill, cystic duct margin negative, incidental gallbladder cancer where cholecystectomy alone is good enough, by and large, practically speaking, in real life scenario, all patients with incidental gallbladder cancer should probably be offered a reoperation, unless, of course, the imaging and staging laparoscopy shows a distant disease. So incidental gallbladder cancer has to be treated very, very aggressively. So these are 2 points I thought I would make. I'm sure Dr. Nag had already emphasized most of these points.
But sir, for incidental gallbladder cancer, I continue to feel that instead of just like whatever is available in literature till now and which suggests we should do more trials, because I feel we do not have answers. Like even today, when a patient comes to the ward, the 3 consultants amongst us will differ. Like as to, like, because we do not have an answer whether pre-op chemotherapy is as good as upfront surgery and adjuvant. We don't really know. So I think more and more such patients should be for trials, prospective studies. Maybe Dr.
Yeah,
Nag.
but till that time,
Yes, sir.
if we are not enrolling a patient in the trial, we should have an aggressive approach towards
Absolutely.
incidental.
And
Yes, sir.
therefore, I think because gallbladder cancer is so common, I think cholecystectomy for gallstone disease becomes even more important. Like taking as you said, being very careful about the sonological findings, removing gallbladder in a bag, and all those things. Like, because bile spill is one thing which has the worst influence on
Yes.
prognosis if it is an incidental gallbladder cancer. So that is
Nag, you were wanting to say something.
Yes, sir. Most of the patient with this thing, difficult cholecystectomy usually have thick-walled gallbladder, and that is associated with that may harbor malignancy in few cases. Any such case, if we are planning subtotal cholecystectomy, and we should convert to open. I think if it is not possible to control bile spill and stone spill there, because that may be
Yes.
change the scenario in few patients. Any patient with SD where calot resection is not possible, even if minimal suspicion of gallbladder cancer, we should convert to open because it is more control way to do these patients, and we can pack up all the abdominal mops and we should take all the precaution while doing these patients. And we can do wash with normal saline or distilled water also in such patient, as we were doing at HCPGI in some cases.
And just again, a very practical tip for the practicing surgeons, that when you are doing the reoperation for incidental gallbladder cancer, you must counsel and document it well, that the final histology of the removed liver and lymph nodes may not show the disease. Because then the patient will come back and ask you, if there was no disease, why did you reoperate? It was an unnecessary operation. So we need to tell them that this is a very good situation for them, because this is the subgroup which will have the best outcome. But as of today, there is no way to find it out. Although there is one paper from TMH, which is a retrospective analysis, where they have shown that in T1B disease, when the muscularis propria is involved, if the PET scan is negative, they said that you need not reoperate because there is no residual disease. I personally don't agree with it till they can prove it with prospective study. I would reoperate upon every patient with incidental gallbladder cancer if there is no distant disease.
So we have had
I do agree with this.
patients with peritoneal metastasis in a month and a half time, So T1B is more like T2.
One more question, which maybe Dr. Nag covered, but I missed that part, which students also ask, and some practicing surgeons have sought my opinion on that. Cholecystectomy done, incidental gallbladder cancer, for whatever reason, reoperation could not be done in time. And now, a couple of months later, the patient comes with a single isolated port site metastasis. So what should be the approach? What I would say is that you do all possible imaging, which would include obviously a chest X-ray, ultrasound, CT, and a PET scan. And if everything is normal, that means there is no other metastasis other than this single port site metastasis, one may consider it as a contamination rather than a dissemination, and do a wide excision of the port site. Of course, again, telling the patient that in all likelihood, you are going to develop a recurrence, and combine this excision with chemotherapy. So that would be the only exception.
I think Dr. Nag mentioned that, like, they consider
Yes.
like
Yes.
this thing as
Anyway, these patients will go for chemotherapy, madam. And we can excise earlier or later, but we should explain
Yes.
patient because that he or she has may develop further disease.
But I tell my students here that I'm very keen to do a questionnaire survey. Has any one of us had a 5-year survival after an isolated port site metastasis excision? That would prove the point.
My practice, sir.
Hmm?
Maybe Dr. Agrawal has seen some cases, but I have not seen.
I would like to do that questionnaire survey for all surgeons who deal with gallbladder cancer, because I presume that it may not show in the next initial few months or maybe 1 year, but later, I'm sure these patients will have peritoneal dissemination. But still,
sir, it is very difficult at our center to have long, more than 1 year or 2 year follow-up in these patients.
no, but if the patient is living at 5 years, we know that the patient is living at 5 years. So
But
I just want to know.
nowadays we have mobile, we can contact
Yeah.
if it is
No,
actually
patient will come back to you if the
they
patient is
don't
living for 5 years.
turn up once because they come far from Bihar and UP and they don't turn up for follow-up after 1 or 2 years.
But I'm yet to see a 5-year actual survival after a isolated port site excision. So my hunch is that it does indicate a dissemination. Only thing is some patients show metastasis early, some show little later.
Yes,
But
sir.
yes, there could be a justification in doing a wide excision of an isolated port site metastasis if you have done CT or MRI, PET scan and staging laparoscopy. Everything has been done.
I think while doing to avoid this scenario, we should take out all the specimen in a bag. That should be practice for all practicing surgeon.
For all God.
Maybe part of gloves may be used if
I fully agree.
formal bag is not available.
Just
Some
an
other thing can be.
improvised inexpensive bag, not necessary commercial bag, but anything can be used, and that should become a routine, definitely.
Yes,
that
sir.
should become a routine. So Anu, you have anything to say? Otherwise, we'll close.
Sir, I think we covered almost all the issues. So,
Okay. Thank you, Dr. Nag. Thank you very much,
Nice
and thank you, Anu. And
Thank
as
you
I
very
said,
much.
that the live attendance at these sessions is relatively small, but as I would keep you informing, we are very happy to note that over the period of next few days and weeks, we get a lot of views of these sessions. So, which means that students and practicing surgeons are watching these videos, which are uploaded on the YouTube site by Dr. Avinash Nag's team. So thank you, Anu. Thank you, Nag.
Thank you. Thank you,
And
sir.
thank you, Dwarika team. Rajan, thank you very much.
Thank you. Thank you very much, sir.